Good morning. As Roy said, this is where the rubber meets the road. How do we take all these cool new technologies and use them to improve patient outcomes, which is what we all want? So how are we going to do that? So what I'm going to go over is what is it that's required in order to adopt new technologies so that they can be used to improve patient care? What do we know about adoption now? What are the opportunities and challenges as we move forward, focusing particularly on the new technologies? So the first thing to think about is that adoption means a continuum of things. In other words, a lot of things need to occur for these technologies to be used. First of all, you need to have the test. Then someone needs to want the test and they need to order it. You need accurate results. And then people need to follow treatments that are based on the test results. Someone needs to pay for the test. And then finally, we need tests that provide benefits relative to the cost and the risk. So we need all of these, but today I'm going to cover particularly, are tests desired and ordered? Are we paying for tests? And what do we know about the benefit-risk trade-offs? Another thing to keep in mind is that there are a lot of different kinds of tests. So when we think about what determines adoption, we need to keep in mind that it's going to vary a lot depending on what kind of test. So I'm going to cover somewhat of all of these. So what do we know about how tests are desired and ordered by patients and providers? Patients. They want it, sort of, when they understand it. So we did a survey. Now, this is not oncology patients. This is a general population survey. And I was really surprised to find out that 3/4 of people did not even know what the term personalized medicine meant. They're like, what? Never heard that before. 3/4. I mean, we live and breathe personalized medicine, right? But when we told people what it meant, they said, yeah, that sounds cool. I want that. Now, the next finding is a bit of concern because we asked people, if you had a genetic test and it indicated that you would get no benefit from a cancer treatment, would you still want the treatment? And they said 84% said they would either want the treatment anyway, or they'd get a second opinion to find out whether they really should get the treatment. So that's a bit concerning that people don't trust test results. Patients, they want it all, especially if they don't have to pay for it. So we've done several surveys of what are patients' willingness to pay for genetic tests. Looking both at gene panels and whole genome sequencing. People are very interested, which is the good news, but their willingness to pay varies based on how much you tell them the test will cost and how much income they have. So it raises a lot of issues about disparities. And when you ask people, they'll say, I really want to know all the results from my whole genome sequencing. Tell me everything. Tell me everything, even if there's no clinical actionability, you have no idea what it means. I want to know everything. But their desire to know everything goes down the more they have to pay for it. So they're happy to know everything as long as somebody else is paying for it. So we have a bit of a dichotomy there, with the caveat being these were not oncology patients. Okay, providers. Some want it when they understand it. There have been 2 very good studies on providers and what they know about genetic testing. There was a study done in North Carolina that found that oncologists were enthusiastic about germline and tumor sequencing. testing in this case. But they really didn't understand genetic tests. They weren't comfortable with them. And a very interesting and I thought peculiar finding was that community oncologists were more likely to use genetic tests than academic medical center. Now I see a nod, so maybe he knows why. This was the opposite of what I would expect. Then there was a study done at Dana-Farber. These oncologists are obviously very well in tune with what's going on. Well, what do you know? There was a lot of variation in what they knew, how comfortable they were, how much they ordered genetic tests. Really, a lot of variation that was very surprising. Providers. So everyone sees changes coming and that the changes are here. One group we frequently don't study enough is genetic counselors, because they play a huge role in the germline side of things. There was a study done that showed that they see huge changes in what they are doing and how they speak to patients. And they see huge changes in the availability of tests that they need to deal with. And then, as we've alluded to in this meeting before, there's the business model aspect of what's going on here, and that the cancer centers in the US are all racing to have the latest new technologies and to apply those technologies. So that's going on along with everything else. Okay, so we talked about patients and providers. Now, is the test paid for? This is what I really focus on. We just did a study of BRCA. Now, this is a very interesting case study because everyone knows about the Supreme Court decision. And sure enough, since then, the number of BRCA tests and the number of panels that include BRCA have proliferated. So now there's lots and lots of choice. And sure enough, prices have gone down so that the prices are now lower than what Myriad was charging. But the really interesting thing was that there's not a single payer that we could find that has a positive coverage policy on gene panels that include BRCA. So not a single one had a positive coverage policy posted on gene panels that include BRCA. So there's a huge missing gap there. Of the payers that had any policies related to gene panels, 64% of them defined all panels as investigational. And as we've been hearing at this meeting, payers don't cover things that are investigational. So payers will cover BRCA, but they haven't yet figured out what to do about the panels that include BRCA. But everyone is moving to panels. Even Myriad is moving to panels. So obviously, this is going to need to change. We did another study on tumor sequencing. And sure enough, this is very challenging for coverage policies. We do a lot of work with payers. I'm not a payer, I'm an academic. But we meet regularly with health plans. We have a payer board with all 8 of the largest private health plans in the US represented. We just met in Chicago, spoke to them about how are you going to make coverage decisions in the area of precision oncology. And they're very happy to tell us what they want, what they're concerned about, what kind of evidence they want to see. And they definitely see the benefits of next generation tumor sequencing. They see it as a revolutionary trend in healthcare, but they're not quite sure how to pay for it at this point. 80% said that it does not fit their definition of medical necessity. 70% view gene panels as being a bundle where you have to assess every marker in that bundle separately versus the sum is greater than the parts. 70% were skeptical about the new evidentiary methods that are being used to evaluate panels. So a lot of things that need to be addressed. Here's a quote from one of our pairs. Personalized medicine has a lot of promise, but nothing frightens managed care folks more than hearing the word promising from an oncologist. That means they want us to pay for something expensive that they don't have any supporting data for yet. Sorry, oncologists in the audience, I know that's, but you know, that's the way they think sometimes. Okay, also we need to have tests that provide benefits relative to the cost. And here I'm speaking of value broadly defined. Even though I'm an economist, I don't just focus on dollars. It's the weighing of the benefits and the risks, which include costs, but it includes a lot of other things as well. We did do a study a few years ago to look at genetic tests more broadly, not just oncology. And in general, the studies show that genetic testing provides more benefits, although at higher cost. And this is what you would expect. This is very similar to pharmaceuticals. But sometimes I go to meetings and someone stands up and says, personalized medicine saves money. And I say, well, no, actually, it doesn't necessarily. But neither does most healthcare. Very few interventions in healthcare save money. They provide better health at higher cost. And that's the bar that we want to look for. We can't hold these to the bar of saving money, because then we'll never implement much of anything. But in general, this distribution is very similar to what we see in other areas of healthcare. That most tests provide good value, but certainly not all of them, and not all of them save money. So we are now doing a number of studies to try to determine the economic value of multiplex and panel tests. And if anyone has figured this out, could you please see me after the meeting? So we have an NIH-funded grant to do this, and it's hard. It's really the hardest thing I've had to do in my 25 years of being in this business, because when you're dealing with panels, each marker on that panel has its own pathway of benefits and costs. And as we were talking about yesterday, you have to consider not only the test itself, but everything that happens along with that test and downstream from that test. You have to consider how the benefits and the costs are going to vary based on how it's being used, the clinical scenario, the downstream costs and benefits. The fact that there's personal utility, that people value knowing. Even if it's not actionable, people have value to knowing. And then if you're talking about germline mutations, that these benefits and costs accrue to family members as well. So a lot of things going on. We published a paper recently in Health Affairs to try to explain to decision makers and policymakers what is sequencing anyway, and how the clinical utility and the economic value of sequencing will vary. Sequencing is not sequencing, is not sequencing. You in the media, you're always reading about the $1,000 genome, and isn't that all wonderful? And people go, wow, yeah, that sounds really cool. But actually, you're talking about a lot of different uses of these new technologies. And so you have to put a framework around those different uses. You have to think about what's even going into sequencing and how that varies. What methods are being used and how that varies. And then how is the output being used? All of those will impact the clinical utility, the economic value, and ultimately the adoption. So now for conclusions. Well, we need more evidence. We've heard that before. I will say that again. At our payer meeting, one of the payers was saying, let's don't forget about operational utility, not just clinical utility, but operational utility. In other words, can providers and clinics actually use the test? Do they have the infrastructure? Do they have the personnel? How are they going to put it into the electronic health records? All of the nitty-gritty details. We need to know real-world evidence on how these tests are actually used. Value broadly defined to be inclusive, not just the dollars. And big data, integrated health systems, that's the buzzword these days. We have these electronic health records. We need to take advantage of that integration. Not only do we need improved evidence, we need careful framing of information and standardization. Frequently when I go to these meetings, someone will stand up and say, we're just going to educate patients and providers. That's what we're going to do. We're going to educate people. And I always go, oh, please, that is not enough. You can't educate people about everything. You need to provide guidance and structure and framing of information so that people can make decisions, but within a structure so that you don't have to educate everyone to be a high-level genetics testing person. Behavioral economics is something we don't apply enough to these issues because how you frame information to patients and providers will greatly impact their behavior, whether you frame it as a gain or a loss. Guidelines can be used to structure decision-making. And one thing that NIH has funded us to do is to develop a registry of what tests are available, where are they available from, are they from, how much do they cost, what insurers are covering, why are they covering it, how are they covering it. So this is going to be a publicly available registry of reimbursement coverage policies. As I was saying, we need methods for evaluating multiplex and panel tests for all the reasons I've already mentioned. One thing I don't think we do enough of is when we do a prospective study, we have an opportunity to gather data on the entire pathway of events. Often we stop and we don't get the data on who's using the test, how do patients and providers feel about the testing and the information they've gotten. What are the outcomes and the benefits and the cost? And it could be very easy to make these studies more useful by gathering a full range of data from patients and providers. And then finally, we need studies of the changing policy environment. We talked briefly yesterday about the change in CPT codes, which I'm still trying to understand, but it seems like it's going to be critical. And the fact that we have health reform efforts, we have changes such as ACOs, that needs to be considered when we think about how all of this is going to move forward. Thank you.
Thank you very much. That was wonderful. So to conclude the session, we wanted to have a discussion about how to return these results to patients. And we already heard many of the physicians don't even understand what these results mean. So now we have to communicate to the patient. Some of these could be very important for them or their family. So we thought of no better person to invite for this than Dr. Patricia LaRusso, my colleague at Yale. She recently joined Yale this summer. Previously, she was at the Karmanos Cancer Center in Detroit, where, of course, she led an amazing phase 1 program. She's doing that at Yale, where she's also the Associate Director of Innovative Medicine. So, Pat,